So first, an apology. So the title is actually a conflation of two different things that we do, and I hadn't spotted that. So we do a lot of basic science and clinical research in drug interactions, and so the website, the electronic decision support, is the translational aspect of that work. And then we do a lot of work on individualized therapy, pharmacogenetics, regulation of enzymes, and interpatient variability, and the drug monitoring, which I will not talk about, but I've got a very quick slide at the end, is the translation of that. And I'll try and illustrate, I think I've tailored this for the audience and illustrate areas where we would be interested in pursuing collaborations. So I'm going to talk about the HIV and hepatitis drug interactions website, which is set up by my colleague David Back and myself, and together with our team in Liverpool, and we've got multiple industry partners for this, and these are the URLs. So start from where Archie was really, which is to focus us completely on what is the need, and thank you for that. So the need is huge in HIV. There's 37 million infected people. We're trying to roll out treatment to the 20 or so million who actually need it urgently. HCV, there's 170 million people infected, and the treatment is transformative. The cure rates now with the new drugs are virtually 100% for 12 weeks. At a huge cost. And hepatitis B, so it's estimated 1 in 3 people in the world have been exposed to hepatitis B, about 350 million people chronically infected, over nearly 700,000 deaths per year. So these are big problems. There are treatments, and they are successful. They save lives. Nevertheless, these treatments carry a liability for harming patients through drug interactions. HIV drugs are some of the most therapeutically risky drugs licensed in man, ever licensed in man. There are stories when HIV treatment was first introduced of people who went in for day case bronchoscopy or took sleeping tablets and then stopped breathing and were ventilated in ITU. There are people who took illicit drugs and died. This is a report of someone, a drug user on methadone who took an HIV drug, and the drug interaction with his HIV drug and methadone caused him to have cardiac arrests repeatedly on the wards, actually. So this is an area where actually people have died, significant harms have accrued. And global surveys suggest, we've done about surveyed in collaboration with other people, around 6,000 people in sub-Saharan Africa, Switzerland, US, UK, and around 1 in 4 people on treatment will have a clinically significant drug interaction. That's to say that the regulatory authorities say it should be avoided, cautioned, contraindicated, or not recommended. Okay, so these are big problems, and yet clinicians only accurately identify 1 in 3 of those really significant interactions. So it's a big problem. And if you look at HIV, there's 13.5 interactions to remember. No clinician is going to remember that nowadays, and I'll come back to that. That's a problem in clinical medicine. Nowadays, the number of facts you need to make one medical decision is growing and growing and growing. Biomarkers, you've heard about that. Algorithms, you've heard about those. Clinical syndrome mapping, you've heard about those. Prognostic indicators, you've heard about those. So you have to remember those more than just the 6 sepsis bits of information to make, and if you look at the number of facts you need to know far exceeds the cognitive ability of your clinician. And the patient population is aging, so with better drugs, this is not going away. There's multiple medical co-meds people are taking, and the available resources are inadequate. They don't cover every single eventuality. So what do? David Back and I decided that actually we did need to address this problem, and so we created a electronic prescribing support resource. So we built a huge database, which for HIV has about 14,000 pairs, and for HCV over 6,000 now. We want to make it clinically useful, up to date, it's updated every week, and evidence-based, and I'll come on to that in a bit. We made it easy for people, so it was traffic lights. It was green, red, and amber, and everybody knows what to do with traffic lights, unless you're Italian. And it was supported by pharma, generously supported by pharma, and more latterly by the specialist societies, so the British and European AIDS clinical associations, Elton John, and then various Glasgow, and then the Liver Foundation, EASL, ASLD, things like that, the big liver societies. More recently, we've internationalized it. It became bigger than just a Liverpool adventure. So it's got an international editorial board. People from Stanford, people from Nijmegen are on it. And it's now covering developing world drugs, so WHO Essential Medicines list, and we're piloting work in Uganda. So what's a brief history? In 1999, we did simple paper charts, and that was all there was at the time, and they became wall charts, and people stuck them out on the wall. There was traffic lights against probably about 80 medications to 100 medications. It was gradually harder and harder to fit that on a piece of paper, so we went digital. We created our own website, and then after a while, it was obvious that this was Mickey Mouse, so we partnered with Thompson Medical, which was a medical education company. Part of their subsidiary was a company called KP360 that organized conferences and produced medical literature and education programs. And so they were a natural partner, and they developed the website. It was redeveloped to its current form about 2010 was the last iteration. And we internationalized it, as I said. And then in 2011, we launched a series of apps for iOS and Android. And then 2 years ago, we interacted with electronic prescribing in one of the biggest, probably the biggest HIV treatment center in sub-Saharan Africa. So this is the Infectious Diseases Institute in Kampala. It's got about 10,000 patients who actively are followed up. And so every single prescription they write in this center, so it's about 300 prescriptions a day, utilizes the website. Okay, so there's an automatic interaction. We have about 4,500 prescriptions a month. What should I don't know if we're successful or not. I can think of areas where I feel we have achieved what we wanted to do, and other areas which have been less successful. I think we are probably the leading drug interaction resource. We are cited in WHO guidelines, in US and European guidelines, so multiple treatment guidelines. I think about 40 sets of guidelines from about 17 countries or territories. In the UK, the NHS guidelines, the standards set for patients, requires every GP letter to carry a reference to the URL. And patients do use that. Elton John funded us to make a patient app. We've partnered with major specialist societies, I think I've said that, and the web metrics, whatever they mean, suggest that actually on the website part of the thing, we have about 105,000 individual users and about 36,000 in hepatitis, and the trajectory is rising. It covers multiple territories. So HIV, about 40% is UK, the rest of the world, 19% US. With HCV, UK and US are pretty similar, okay? So coverage is one of the things that we're interested in trying to improve. External funding, so pharma funders in the last 5 years, about 1.3 million, but we've had funding from charities and specialist societies as well. So I guess this brings us to the point, back to the patient need. We've got this amount of data, sheer amount of data that we have to bear in mind, and there's a tension between having a specialist know all that and actually the needs of a patient, which is to say that every patient should be able to go to any hospital, anywhere in the UK at any time and get the best possible care, okay? And that includes safe prescribing. And how do you reconcile the two? And I think that electronic prescribing support is an important part of that. What could we have done better? Well, I'm absolutely hopeless at fundraising. So the only model I know is the begging letter annually, which is what we do. We could have defined ownership of the website. The website hasn't got any IP. This is all public domain. We predict what the interactions are. We are different from other websites, so other resources. So, you know, the drug company will issue the interactions that they have done, the few interactions that they've done, probably about 19 studies, okay? We cover 600 interactions, including the ones they didn't do, and we grade it according to a WHO grade-based system. So we give a recommendation and we grade the weight of the evidence, okay, in a transparent way. What could we do with $1 million? That's always a question that's asked of me. I think that a website is Soviet style. It clearly needs to be decluttered and mobile responsive. 21st century prescribing is going electronic. We have to reconfigure the website fundamentally. So here's somewhere where we're looking for people who have that expertise that we and our current collaborators do not. You know, things like being compliant with interoperability with other NHS systems, electronic prescribing, you know, HL7 messaging, getting some drug ontogeny. For those of you who know what that is, DMND or SNOMED CT or something like that. We want patients. We want patient-friendly apps. One of the things that we're trying to do is to make an in silico tool where we can create a sort of a virtual patient on those drugs and then predict their drug interactions. And so there are other areas, particularly other areas that are non-infections, cancer, things like that. And I'll finish off with drug monitoring. So clearly there is variability in the way that patients respond to their treatment. Interactions is one of them, but there's plenty of other areas, diet, ethnicity, body weight, gender, pregnancy, young children, patients in intensive care. They all handle drugs differently, and we try and get a handle on making sure that we don't just give, we make sure we give the right amount of the right drug to the right patient. So we have all those various facets of treatment. And as a result, we developed as part of that strategy the ability to measure drug within a GCLP setting, which is what we had, and the university rolled that out. We developed a national drug monitoring service for patients to individualize therapy, and that was spun out by the university in 2006. We are looking for new areas of work, including urine-based drug testing, using an aptamer approach, and various, but I can talk about those later. Thank you.
Thank you very much, Saye.